One of the things in that she's going to be talking about is the necessity of a roof over someone's head in order to maximize mental health. She's going to be talking about housing first. One of the things she's going to be talking about how one size does not fit all. And I think today, as we've heard the other speakers now, one of the things that comes out, and I know that Kim will bring this forward in that, is a word in that the last group in that just emphasizes several times, is passion. The number of speakers that we've had today now have all spoken with passion about what it is, and it's extremely important. Now, I'm not going to say much about Kim. If you look at the bio that's in the program and that, you can tell she has her fingers in everything goes on in the department regarding the community and that. I will say this and that is that if you will be patient with Kim, because she is so quiet and shy and reserved and has a hard time in that voicing her opinion. But I'm pleased to present Kim Hammack.
Good afternoon. I will tell you, Brian, that was perfect because I feel like the commissioner right now. I feel like I'm almost in tears. I feel in awe, and I actually feel intimidated. And I speak, and I have spoken in front of hundreds of people. But with the group of people that have spoken today, I feel in awe and I feel intimidated. So as I try to sit up here and talk to you, I got 3 stories, and anyone that knows me also realizes when you give me 30 minutes, I already talk fast. It may pick up the rapidness of my speed of speech, but I'm going to try not to do that. But it did when I listened to the speakers just a minute ago. There are 3 stories that I want to share real quickly that kind of sets the context of why housing is important. One of them was when Joel was talking and about the importance of recovery and the importance of peers and listening to our peers and our individuals who are peer specialists who share their stories so raw in what they've done. My office being next door to Mike Autry is probably the biggest blessing I've had working in this department. It keeps me humble. It keeps me focusing on why recovery is where we get. Again, I was a clinician, and as a clinician, I have never had one person, I've searched for them, I've tried to find them that said on their treatment plan, their goal was to be in day treatment. That their goal was to get their medications. Their goals, or our goals, is to have a meaningful way to spend their day and a place to lay down their head. And we had the opportunity, myself, Mike Autry, and a peer specialist from JBS, Jerome Dorsey, that NASHPA chose us of one of 11 states back in 2013 to go to Michigan. And they wanted us to go to Michigan to look at the Michigan's peer program, and they were doing what they is their continuing education. They have 700 certified peer specialists. And the reason why they wanted me to go was, how do you fund this? How do you figure out how do you fund this? And sitting through those classes, the classes I chose to sit through, and the only people there that were not certified peer specialists were the state representatives that were coming. And it can only be 1 per 7 states. One person that could be on that team that was without lived experience. Everybody else had to have lived experience. So I was one of 7 people that was attending this conference of over 700 people, and the class I chose to go to was housing. And as I listened to them talk about housing, and as I listened to them talk about what these individuals in Michigan did of going under bridges, and their outreach and going into the jails, and what they were doing to link people into housing, and as they were talking about 811s and all these different acronyms they throw out about housing, I was infuriated. I got on the phone back to my person here, Jessica Hales, and says, do we have tent cities? Do we live with this? Is this what we do? And the individuals in those rooms who were educating me and the rest of us on what we needed to do to try to get someone to choose to come off the street and go into a house was our certified peer specialist. So that was one thing I wanted to share, that as I listened to them talk, and as they shared their story, and then we started coming to these conferences and listening, and I listened to Christy Collins. And Christy Collins, who sits up here by me, looks like me, does everything, and her lived experience, and she shared her story, was so much powerful than anyone listening to me. Another story I want to share very quickly, when Avra was talking about the program at Hillcrest. Hillcrest is the RISE program. These are kids who are DHR. They have failed in every program in the state of Alabama. And when I say failed, and again, this has to do with living. I'm going to get this back to housing. Failed in a residential program in a children's world means you lived in a locked residential unit. Your house is locked. You go to the bathroom when somebody unlocks the door. You get in line to get your medications. You eat when it's time to go eat. And the reason you're there is because of your mental health issues. No crime, no thing you're having to do to satisfy a juvenile probation officer. You are there because you need psychiatric treatment. And so our mental health providers who have kids there through multiple needs. And so that you know about this, how most of this is funded, you either get there through a DHR contract, or if you're a child with mental health, it's through multi-needs funding. It's $300 a day, every day, 365 days a year. And most of them stay there 6 months to 18 months, averaging about a year, as their home. This is where they live. This is where they go to school. This is where they involve in their community. So the best thing I did was listen to a proposal that John Brock wrote, brought it to Mike Autry, had us listen to it. Dr. Craig and Steve McCabe was willing to do it. We funded it and got out of their way. And we let the peers take over. I told Audrey Tripp the thing that was going to be the most frustrating thing about this program is these kids were going to discharge from this temporary residential living, because that's a treatment program, to a home, to where they're not going to have certified peer specialists to link to continue with their continuum of care in their home community. The last thing I'll share as I get into this is when Jimmy Walsh called me and said, "You're going to be speaking here, we've got this done." I was like, "No, sir. No, sir, I'm not." He said, "Your commissioner says you are." And I said, "Yes, sir." "Yes, sir, I am."
I knew where to start.
And when he told me I was going to talk about housing, and I'm going to really fly through some PowerPoint presentations, of all the presentations I've ever put together, this is probably the one I've struggled with. One, because no one's ever known me to talk in 30 minutes. Second, you can't know why we're working on what we're working on if you don't know where we've been and why we took this path. So truly, I'm going to go through these first set of PowerPoint slides very quickly, but just to set a quick tone to let you know about housing. I can tell you our commissioner coming in, and if you've read the recent thing from the governor where there was some emergency funds given to do the housing, housing is important. And if you leave with nothing else today, and Dr. Craig made sure I said this, housing is treatment. Housing is treatment. We cannot think of housing any other way but treatment. And I'm going to show you how some data that we've got is going to show that. Oh yeah, it does work from up here. They've had me nervous. When Dr. Feldman's things couldn't move, I was like, I'm not going to be able to do this PowerPoint. One, I think all of y'all already know this. We're part of the department and we have a commissioner, and with our commissioner, I think it's working. I'm going to focus on what we're doing in our substance abuse mental health, and Diane Boyer, our associate commissioner. With the Department of Mental Health, we have to run state hospitals. By law, we have to serve a committed patient. We don't have to run state hospitals. We have to serve a committed patient. We have served committed patients in a state hospital. The other thing that the Department of Mental Health can do is if we contract with somebody, we have to certify that program, and we have a certification with our within our mental illness division as our each one of our programs. Also with the Wyatt settlement, we have advocacy. It's very important that you have internal advocates who are able to go in and check on the rights of any individual to really be a check on the Department of Mental Health. In our mental illness division, our purpose is to make sure that we establish a comprehensive community mental health system. And with this particular area of my focus, we do this with our SMI, that's severely mentally ill adults, and seriously emotionally disturbed children. Many of you, if you've heard them talk about, started with some of our focus of trying to move to the community. Back with our Wyatt versus Stickney case, where it says that everybody has the right to have treatment outside of a psychiatric setting. We started working, and I'm going to have to move because I have to look at this. and my eyes ain't quite as young as they used to be. But part of this was the foundation of this litigation significantly influenced what the Department of Health started working on. It became very important that we really worked on trying to move from large-scale institutional walls out to community-based mental health care. At that same time, we started running a parallel line with Olmsted and really following those Olmsted belief systems of serving someone within a community setting. So how do we start developing our continuum of care? We steadily started moving this, and if you heard some of the other people talk about, if you look at 1971 alone, as shared earlier, we had 5,000 beds at just Bryce Hospital alone. We reduced that to 400 beds in 2004, and then by 2014, we were down to 268 beds just in this one state hospital. We used a census reduction, and without the community mental health centers through decades, there is no way the Department of Health could have achieved any of these outcomes that we were trying to achieve. And we worked towards moving out of the inpatient beyond Wyatt and continue to work on different types of projects to invest in our belief system of someone living in a community. From FY09 to FY15, the bed reduction of our state hospitals was 52%. We had 52% less beds. If you will look at the number of people we served, if you look in 2004 at over 4,000, and in 2016 we had served 954 individuals. If that wasn't enough, we got a new opportunity. Commissioner, I can't remember how you said it, but I appreciated it. What was that about, a crisis? We never need to take advantage.
A crisis is a terrible thing to waste.
A crisis is a terrible thing to waste. So in 2012, we decided we had no more way to avoid this wonderful opportunity. So from 2009 to 2012, the Department of Health, like many state agencies, had experienced cuts. Our cuts added up to about $40 million. At the same time, this is when we started the Medicaid managed care efforts, and that's important in our timeline because the Department of Health was required to be a part of whatever that was, because if you look at your cost and how to do cost savings, the mental illness care of somebody's physical health is one of the areas in which we've needed to try to have some cost savings. So we started working on how do we try to deal with these $40 million cuts and work with our partners to try to achieve this. So, what do you close? Where do you start? You heard me tell earlier that we have to serve a committed patient. So do we close community mental health centers? $40 million. Do we close community mental health centers? What happens if you close community mental health centers? You end up in the jails, you end up in the hospitals, we make a worse situation. So what did we do? Do we close our residential programs with our mental health centers? If you close the residential programs with mental health centers, where do you think these individuals will live? What will be their home? The street, the bridges, the jails, the prisons, the emergency departments. Do we close outpatient services? They can no longer be able to get any of their medicine. They don't have those therapists to talk to. Do we close those? Or do we stop our recovery services? Do we not allow them to have peer specialists? Do we not allow them to have drop-in centers? Do we not allow to have the type of programs you work towards employment? So we work towards trying to do a civil commitment and work on our civil commitment process and develop what would be a systematic process of serving a committed patient. We restructured our commitment process with existing law. The law does allow us to serve a committed patient in a state hospital or a designated mental health facility. The designated mental health facilities are either hospitals or crisis residential units. We wanted to have ability to have levels of care of where you could serve a committed patient. So in FY12, on August 31st, 2012, we closed Rural Hospital. October 31st, we closed Searcy Hospital. April 1st, 2015, we closed North Alabama Regional Hospital. So the three standing hospitals for the Department of Mental Health is Bryce Hospital, that's at 268 beds, Taylor Hardin, who is 140 beds, and 96 beds at the Harper Center. These are the three standing state hospitals for the Department of Mental Health for adults today. So we started working on, if you look at that, from August of 31st, 2012 through 15, the closures of those three hospitals was 412 beds. We had to do a reduction program with Region 2, that's the area that serves Bryce, and we took another 60 additional beds offline. So if you look at the number of total of beds from 2012 through 2015, we closed 472 beds. I want you to remember that, 472. Because we hear people talk about we don't have enough beds. But let's talk about what we put on. We started opening up the designated health facilities, and if you'll look at here down at the bottom, 436 beds are hard beds we put in place. Those are hard beds to serve committed patients. We also had contracts with another 608 beds. Those are access to beds. It does not mean there's a bed there. That means there's access, but you have access now to 1,300 beds. We started looking at then how, because when we did this, and everybody was worried and continues to be worried and should be worried, we run a waiting list. People sit in jails. Can't get them in. Dr. Craig can show you with the data we've tracked, with the closing of the hospitals and what we've put in place, we've allowed us to remain at status quo. Status quo is not good enough. There is still people waiting on beds. Our waiting list was running around in the 50s and the 60s, and it will ebb and flow with whatever's going on. And I'm talking about Bryce Hospital, just civil commitments. And looking at how can we now try to move some of these. We work very closely with the Alabama Hospital Association. Many of our partners are those hospitals, because that's usually where those individuals are sitting. So we started working on how can we try to bridge this and move outside of our silo system and move our hospitals into being a part of our system of care. Some of the key components we did with this is that we developed a civil commitment protocol process to get the mental health centers involved a little bit earlier, to get them involved at the time of the commitment. We moved to a centralized way in which we access those beds, and we track our data through our Gateway database system. What we realized was important, and this is going to be a theme, and it should be a theme to everything we do from now on. It will be with the projects we're working on at the department. Everything should be person-centered. So we started talking about, and if you talk about person-centered, it's about that person. That person is driving that. That family is driving that. So we decided if we're going to make any indention in what's going on in Bryce, we got to know what's going on with that person. What do they want? What does their family want? What are the barriers? How can we move it? So what we decided to do with me and Ms. Penn, the director of Bryce Hospital, in December 2016, we started a statewide staffing of every individual. All 268 individuals on the first Friday of every month, a mental health center has 1+ individuals that participates with a coordinated system of care. And we start talking about each individual. These are forensics. There's about 100 forensics sitting at Bryce today of the 268 beds. We talk about everyone in there, and we develop a treatment team. What happens is that the social worker comes in and talks with each one of the community mental health centers, and then they bridge this information back to the treatment team. We involved our attorneys so that we could get those HRBs, it's a hospital review board, some of what we have to do legally to get a forensic out of the hospital to try to cut down on that time. What that has allowed us to know from some of this data that we've looked at is that we've looked at our waiting list. Our waiting list and work with the hospitals have shown us that there are individuals that didn't need to be committed. The reason they were getting committed is because they ended up back in the emergency department. They ended up back there because they had no home. They were homeless. When you let somebody with a heart condition be released back and they're homeless, they're not going to end up in the news like somebody being released from the hospital that's got schizophrenia, that's got violent tendencies when they are not well. We realized that looking at our residential vacancies and some of what we needed to move, we needed to try to figure out what other resources we needed with housing. We also knew from our residential, looking at our beds that were filled, there are people there that also knew those resources to be able to move to the next level. We looked at our readiness data, what level of care they needed, and some of our specialty populations. We worked with our juveniles, deaf services, ID, and these are people who have mental health, but other areas, substance abuse, forensics, sex offenders. Sex offenders are very hard, almost impossible to move into housing because they can't be anywhere that's within so many feet or so far from some type of school or something, if the state laws aren't enough, the city and the county laws are going to throw in a few more laws. We're almost going to have to put them on the moon. Dr. Craig talks about Sheila Hurley's Sand Mountain or somewhere we need to try to build some places, but the sex offenders are probably the hardest for us to try to move. And then some of how we can link into the nursing homes. Right now we have several individuals that can move into a nursing homes today, but nursing homes don't have to take them. They came from nursing homes, but we can't get them back. And so how do we start looking at the type of solutions we need? We need to focus on housing, outreach services, recovery supports, quality measures, and paying for performance. This is important. If we're ever going to change our system for what we've been working on for 3 years, and unless we invest in our system to pay for these things here that don't exist, you've heard every speaker talk about it today. Housing, outreach, taking it out. If you think I'm going to go into my appointment when I'm that complicated group you've heard them talk about that's at top end, that's not going to happen. We don't do outreach and invest in it, recovery supports, quality measures to know that we're paying for performance, we will not be able to change the system. So, does DMH have enough beds? Do we? We keep hearing legislation and we need more beds. I appreciated the speaker earlier that talked about wanting to build more prison systems. We have the conversation every year. We need to build more state hospitals. Please give the money to the Department of Health to allow us to invest in housing. Housing. We don't need more state hospital beds. We need more housing. We hypothesize that if we were able, right now from our own data, to have housing, treatment, to put someone in that's in these emergency departments, that are in the jails, that are in our own state hospitals and our own residential treatment programs, we would not have a waiting list. We would have ability to try to link into this. So what are we going to do about that? We started examining our housing continuum of care. We know that it's important to look at our current landscape and analyze what housing do we have available, what housing do we need, and the opportunity to separate our housing from our living so that individuals can, right now in our residential programs and in treatment, you need it. Sometimes people get tired of me talking about my father, but because I'm speaking, I get to talk about my father when I want to. But in 2010, I got called to a hospital and my father was told he had 30 days to live. 30 days. And that we needed to take him to the rehab nursing home, sign him in, love on him, figure out what he needed to do, what was his plans, and let him die with dignity. And we listened to the doctor, and we carried him to the rehab. And I don't know what sparked in my father. We have jokes about it with my mom. But he was a 6'1" individual, had gotten down to 105 pounds. But he had spark, and he started getting better, and he got better. And he could go home. And we took him home. And 9 months later, my father was, I appreciated the story earlier of what's being in recovery of substance abuse versus what I call a dry drunk, and that was my dad. And I tell him all the time he was rolled hard and rolled up wet, and he was the most passionate, loving, incredible daddy that anybody could have, because there's a difference in a father and a daddy. And he was my daddy. And so we took him home, and he had a medical issue. He had COPD. He had smoked all of his life. And 9 months later, he got sick. Went back to the hospital. And that doctor looked at me, and he yelled at my dad, and that was about in. And I shared with him, you're not going to yell at my father. Well, I told you to put him there. If you want to have any chance in him living, let him stay in that nursing home. My father would rather die living 1 day in his home than 10 years in a nursing home. Our consumers would rather die living in their house than having to be locked in a program just because we're trying to keep them safe and trying to be that maternalistic. I heard a statement, we're very good at trying to fish for someone instead of teaching someone how to fish. So one of the things we need to do is to figure out with our services, how do we not make that so dependent and separate it to where you go get your services just like my father went to get his services, which I will tell you, he didn't die for 3 more years, so they don't always know what they're talking about. To be able to know then how we need to do this, we needed to know what is our current community system. We serve around 108,000 people. It says 21 there. We've had a couple of mergers, so we have about 19 community mental health centers. Diane Boyer, coming on board, was inheriting all of this and decided we needed to spend some time with it. So she told us within our MI planning, develop what was called our MI planning committee, and put a core group of folks to say, now that we've done what we've done with the hospitals and tried to transform it, how do we keep doing it? I like the comment earlier, and that's what we've said often. Sometimes you need to stop talking about it. You need to start. You just need to start. So Diane charged us with starting in March 17 with the next phase after what we've been working on under Dr. Bell Chambly for all those years with the hospitals, and how do we move forward. So we put our core group together to start looking at some of the long-term planning for community mental health. How do we look at those housing services, the meaningful day, the outreach services, the recovery supports, developing those quality measures? We realized we had to start with housing. If we don't start with housing as treatment first and foremost, the rest is not going to happen, and we're not going to stop the vicious cycle. So we started looking at where in housing do we need to start with? Well, you need to start with the most least restrictive, most integrated, and that is permanent supportive housing. Permanent supportive housing. So we needed to look at how to determine what that affordable housing needs were for our individuals with SMI, identify where that current housing needs existed in our congregate housing, what do we currently have, and then identify those type of supports we need to be able to move this more to the community. Now, one of the things that I will tell you happens when you're in a poor state, and we dealt with consultants, I can tell you we have a contract with Navigant and a group called Technical Assistance Collaborative Incorporated, TAC. And one of the things, the reason why we brought them in, when you're in a poor state, and we don't even say poor to them, and I appreciated Avra's, I worked in adolescents too, so I use too much adolescent slang, we are po. And the first time I said we were po to John O'Brien, who we're very blessed to be a part of our team, he says, Kim, what did you say? And I says, po. And he says, do you mean poor? And I said, yes. And I realized that I'm Southern. Well, then when Dr. Craig said we are po, I thought, see, I told you, we are po. But one of the things that happens when you start having, and y'all know this, any little bit of money, we start infighting amongst ourselves about where our money should go. We start saying, let's cut the day treatment programs to fund the drop-in centers. Let's cut our residential to fund our housing. I will tell you, if you have that type of mentality and the department has to continue to cut within its own self to find its problems, we will continue to crash. And so one of the things we wanted to be able to assure ourselves of is, what is our current housing? Could we shift some of our housing funds? Do we need that? Like that nursing home I talked to about my father, if we had to take my father straight from the hospital to home, he'd have died. I needed that level of that rehab nursing home. That's what our residential congregate living is. It is a temporary housing with the treatment in it that's needed for that rehab piece to get them home. So we started looking at how much housing do we have that's non-congregate. All of that is what we have access to with the department and contracts. You're less than 1,200 beds. That is either an apartment of some kind of supportive housing with a case manager or somebody, up to a mom. Basic homes, basic group homes, 706 beds. It's not a lot of beds when you start talking about we're serving 108,000 people. 678 residential specialty beds, and the stabilization beds are helping with the commitment, so they don't get to count as a part of the housing beds. So if we can't really look at losing this, because this is foundation services that are important, this here is the services they get. We want to look at the services they get in a residential setting to see what's important for them to also get in their home. But we realize the importance is you got to surround that member, that individual, with those needed services, whether it's in the residential program or in their home. Their home is treatment. So you got to look at how do they spend their meaningful day. When you was hearing them talk earlier, if you're depressed and you've lost whatever that activity, whatever it is, it's going to make you sick. Meaningful day is important. What other services and who are the staff and the outreach to be able to get that done. So we morphed our group into what was called a housing leadership committee. We realized we didn't have the right players in here. We've used our centers, our hospital partners, NAMI, our family members, our consumer advocates to help us solve this problem. We can't solve this problem without our housing partners. And that's not strong with the Department of Health. Our commissioner got on the phone with Nashville immediately and started saying, give us some relief, give us some help. And he linked her in to Marie Williams over in Tennessee, who started like a firecracker and said, I just started calling. I thought, I can do that. We can call people. We can call the Housing Finance Authority. We can call HUD. We can start doing that, and we can try to move there. So we used TAC and Navigate to help us do that and added them to our consulting team. So we started working on housing. Here we go. We expanded our members to that core group I told you about to add the Housing Finance Authority, HUD, our affordable housing, all of our housing folks, and Medicaid. Again, Medicaid can't pay for housing, but all of that wrap that's needed with it, those are areas in which they're an important partner, and they're always a partner at the table with the department, and we're appreciative of that. So we started talking about we have to develop a strategic housing plan. We've got to develop goals that are actionable and that will energize our ability to start getting permanent supportive housing and our opportunities. We have to determine who is our target population and how to create those resources for the most vulnerable of our SMI population, that upper echelons of who we're talking about. And I think we talked about it earlier. These are the ones that are the most expensive. If you take the ones that have been in and out of those hospitals, in and out of jail, in and out of all these settings, and figure out how to wrap them. We got to create a unified state plan that involves everyone across the board. Any of y'all heard of what's going on with the VA? And the VA is already way ahead of us on trying to do this with beds and getting folks from there to these beds and having these set-asides. This is what we have to do within the department and reinforce the transformation of our statewide system. Housing is recovery. Housing should be a part of the continuum of care. It should be delivered consistent with the evidence-based guidelines, and housing first. You can't get everyone prepared or they never will get in a house. Housing first, and the partners that are key for implementation. It's going to take everyone. It takes the community, it takes the county, it takes the region, it takes a village. The important things about permanent supportive housing is this is community-based, it's affordable, and it's safe. It needs to be flexible, and it needs to be where the person can be their own tenant. But really what's important is these related services. Some of the services we think about that we don't get people prepared that we've heard from our housing partners is how to be a good tenant, how to make sure you're keeping what you're doing. We've heard people about, they get very connected to our individuals and somebody burned a house down. Burned their apartment down or burn it inside of it. They didn't want to give up on it. But the thing is, we have to learn that some of what we have to teach them is things that they didn't learn in their home. Things they didn't learn, things that they don't have the skill set for. You can see how housing and all of this is all connected. This talks about some of the different areas of where you have to have your funding and what are those resources that have to be a part of it. And that, again, person-centered. If you will look, that individual has got to be at the center of the housing and the resources that have to cover them. They're telling me I'm out of time, but I'm going to quickly put this up here. You will see that it reduces your emergency department. It will decrease your inpatient admissions. It will reduce your use of psychiatric inpatient care. It will improve health status, and you will have better mental health outcomes. And you reduce substance abuse as well as they've shown improvements with people with HIV. For our population, you increase their psychiatric stability, you increase community tenure, and you provide more stable pathway to recovery. I'm going to move on through it because I am out because there's a couple of things that I think is very important for you to know. We are developing the strategic plan. We've had a few meetings. We started in October. In October, we brought this group together. They put together 4 work groups. The work groups are working on utilization. How do we work to get more of what we need with those types of apartments? We've looked at eligibility. Some of the biggest problems with eligibility is homelessness. To define homelessness by the federal definitions means that you have to have been truly on the street homeless. We currently have beds that are open that we can't put someone in because they can't meet the definition of getting in that home. So we've got to look at how do we change some of those definitions. We thought that consumer input was important, so WINGS, Christy Collins herself and a group of folks went around and we interviewed consumers to see what do they want, what is their needs. We talked to people who are in hospitals, people who are living in residential. We have had our other work group that we've had come together has also been our services. So what are those services and how do we need to realign? And you've heard everybody talk about it again today, workforce and training. How do we have the workforce? And the workforce and training is just not us. It is with those landlords. It's with those individuals who are over those housing complexes. Our next steps is next week we will have our consultants come back with our work groups to start working on what our plan is to try to work on strategies to develop this plan. It's a 5-year plan. We plan on getting that finalized in February. We will draft the strategies and the action steps and finalize these in March to start trying to have a permanent supportive housing plan by April. This has been an aggressive process, but we realize if we don't get what we need for housing at a time that we can really give a plan to our commissioner that she can try to use with this legislative process, we will be another year off from what we need to do. We can't move this system. When someone was talking about we need to start, the department has started. But we need all of you to continue. I thank you for all you do and appreciate y'all having me here.